we're such a copycat industry.
Yeah.
If we can highlight and really bring to light the good, no matter how narrow they are, but the good interactions and the good case studies that are happening, that we could expand and really kind of shift healthcare.
Welcome to Revenue Cycle Above the Bottom Line, the podcast where we dive deep into the world of revenue cycle management. I'm your host, Tim Reiner, and in each episode, we sit down with industry leaders, innovators, and experts to explore challenges and strategies shaping the future of healthcare revenue cycle. Whether you're a seasoned professional or just starting out in the field, this podcast is your space for thought-provoking conversations, actionable career learnings, and discussions about the latest trends you need to know about. Thanks for tuning in, and let's get started. Today, I have the pleasure of sitting down with Boyd Stewart, Vice President of Payer-Provider Collaboration at KLAS, and Dustin Cragun, Vice President of Revenue Cycle Management, also at KLAS. Gentlemen, welcome to our podcast, Revenue Cycle Above the Bottom Line. I'm excited to have you here today.
Thanks, Tim.
Why don't we start off explaining a little bit more about your organization? The way, and you can disabuse me of this notion, but the way I think about it is it's like sort of the good housekeeping seal of approval, or sort of consumer reports for, healthcare software. Is that about right, or what would you?
No, I think that's fair. KLAS started almost 30 years ago. Our founder worked at a healthcare IT company that was getting ready to go public.
Okay.
And as happens, it was not illegal at all what they were doing, but behind closed doors, they're saying, okay, how can we help our books look the best? And so what costs can we cut? What are things we can do? And support was on the chopping block, or a lot of their support. This disenchanted Kent Gale, our founder, and he looked around and saw there's no one really here to hold vendors' feet to the fire to keep the promises that they've made to their customers. Yeah. And that was the catalyst and of the formation of KLAS and what we do.
And so what year was that around? Like, that must have been in the era of like sort of the initial host systems that
1996.
Okay.
He worked for a lab system company and he worked for others and a lot of different healthcare IT companies at the time.
So, we don't generally hear a lot about research in revenue cycle. Kind of break down what the research consists of in the way that you guys kind of engage with.
Yeah. So the research really is experiential. So there is a lot of power and a lot of value in talking to rev cycle leaders or whatever. We happen to be over the rev cycle department, but we have clinical and imaging, all these different pieces. And so there's a tremendous amount of power and data associated with the experience of using a solution. So as an example, if a provider has spent millions and millions of dollars on a solution, that's a vested interest to another provider. Say, hey, how is that going for you? What's it been like? And even if it's been good, any pitfalls we should be worried about, such as implementations or anything like that we can kind of shore up ourselves as we engage with this vendor. Yeah. And so that's the type of research that we capture, and then we share openly with the providers.
Kind of getting that lessons learned.
Yeah.
That experience of what it's like to be a customer. Boyd, I understand you came from a background of kind of pharmaceuticals. Tell me a little bit about that journey of going from that industry and to KLAS Research.
Yeah, that's a good question. It was interesting coming out of college in the early 2000s, getting a job with a large pharmaceutical company, and really had the intent and the purpose to help healthcare, help people like my grandparents and people like my parents, and quickly saw how much impact I wasn't having. As an individual. I know the pharmaceutical companies do a lot of different things, but individually, I didn't feel that movement. And this was in the days of meaningful use and expansion of the electronic medical records. I remember being in a clinic, and this physician came out of his office with his laptop, and you could if there was a way to see the fume coming out of his ears, there's smoke coming out of his ears, as he clicked and clacked and stuff, and finally got frustrated. I was standing right there, and he threw his laptop across the hallway, and then ran after it and jumped on it.
Oh.
And I knew well enough at the time. I'm like, well, maybe I don't have a conversation with him today, and so I excused myself. But it was that where I started saying, okay, where can I help impact healthcare? Where can I give a positive influence and impact on patients and caregivers and the like?
Now, had you had some background in healthcare? Like, did you come from a family that engaged in healthcare, or as other than just patients, or was that just?
No, I just, I wanted to serve. I actually went pre-med when I went to college and did a couple shadowing events with physicians, and quickly realized that I didn't have the stomach for that. Had the caring, had the concern, but not the not the stomach for it. So.
Yeah. So your role has shifted recently. So now you're doing a lot of the payer and provider collaboration. And you were telling me earlier that the K2 summit is coming up. Like, dive into that a bit more. What does that mean? And kind of what does your day-to-day look like as you're engaged in that kind of bringing together of payers and providers?
Yeah, so I came from the revenue cycle side of research. You and I have talked for years, and just trying to report on those things. And every year I'd get together a lot of folks like yourself and get feedback on the reports we'd done and the reports they'd want us to build out in our roadmap. And without fail, they'd say, yeah, keep measuring this core system and keep measuring these other vendors and these topics. But man, if you can help me with my local blues plan, if you could help me with the big national plans, if you can help me with these regional ones, that would actually move our bottom line more than these vendors that are trying to help us. And you find there's a lot of forums for both payers and providers where providers can get together and bemoan the actions and the activities that they're experiencing from the health plans, and vice versa. We felt like there was ways to highlight successes that were happening because we wanted to breed more, and we felt like we're such a copycat industry. If we can highlight and really bring to light the good, no matter how narrow they are, but the good interactions and the good case studies that are happening that we could expand and really kind of shift healthcare.
Yeah, people take notice, and there's like a momentum that builds. So, Dustin, you have a different background. Your current role is in the rev cycle research. So, where did you start, and what brought you to that point?
Yeah, good question. So I was actually on it with a post-acute provider in Utah for 20 years, and I started out, ironically enough, in the PT, OT, speech kind of services, which I am not one. I just somehow I kind of fell into that. And then about 10 years into that, I got pulled into the rev cycle, which always makes me think that rev cycle leaders don't actually choose that. You kind of get sucked into it a little bit.
Selected,
Yeah, but it was great, and I learned a lot. After about 10 years, though, I don't know how to describe it other than I think I just got a little restless, and I felt like, what else could I maybe be doing? And so, as luck would have it, I actually called Boyd. And because I'd seen on LinkedIn that Boyd had a lot of contacts in RevCycle. And I'm like, hey, you seem to be connected to everybody. Hey, help me out here. And he goes, I would be happy to help you, but I want you to look at this role at KLAS first. And then rest is history.
So what kind of unique perspectives do you think that your work in that post-acute kind of gives you in your day-to-day role?
Yeah, and I think this is the thing that I feel most comfortable with or at ease with, is that I still always think about the patient. Because when you're in rev cycle, it's really easy to look at numbers and just look at the financial aspect of it. But what you learn pretty quickly, and you have to learn, I think, is that behind those numbers, there's a human being. There's a family that's struggling to make ends meet, and you're about to send them a very large invoice, and even financial clearance. Are they going to be covered to get their and so all of those perspective, and I guess the human side, the humanity piece of that has always stuck with me. And so even though I'm one step removed at KLAS and we're assessing technology, like I think about vendor relationships. I had great vendors when I was doing it, and I couldn't do my job without great vendors. And so I try to keep that in perspective, as like I help vendors improve, and I'm talking to providers and trying to match that just to improve healthcare.
So it seems to me that KLAS has a kind of a unique culture. Like, tell me a little bit about the company culture at KLAS Research, and like approximately how many people work there and stuff. Give me kind of the rundown of the organization.
Yeah, so we're about 250 folks. Almost all of us do research. I know you and I personally interview you, about twice a year, and there's an excitement of finding the truth. We try to be very curious, open to feedback, and really just try to uncover the why and the how and the intent behind folks. We don't celebrate when vendors do poorly. We don't celebrate when they do greatly. We try not to have an opinion and really talk to as many people as we can so that we can aggregate that and really provide, if we're very mission based. So it's about, improving the world's healthcare through insights, transparency, and collaboration.
So let's dive into some of the industry highlights and landscape. Working with a vast number of healthcare organizations, you can kind of sum up the revenue cycle into a couple of sentences to describe our environment. How would you describe it at this point?
You know, it's interesting when we see, I think there's some optimism when you look at the amount of innovation and investment and just technology-wise that's going into it. And both so there's that.
AI.
AI and machine learning and
speech
generative and all
generative AI.
There's
all kinds.
amazing things happening. And what we can do with bots is so much we could even do even 2 years ago. And at the same time, I talk to provider after provider after provider says it's as hard as it's ever been to get paid on a claim.
Yeah.
So it's that both and. And so at what point do we break through?
What does the current research kind of reveal about denial management and like perhaps the trend of like lowering reimbursement? I hear a lot of providers complaining about Medicare Advantage reimbursement, and some states are looking at cutting some of their contracts back. What else is kind of showing up in that spectrum within RevCycle, and that denial management and kind of lagging reimbursement area?
First of all, I think we know in RevCycle, when you talk about denials, you're talking about a pretty big ocean.
Yes.
It could depends on what denials that you're talking about.
A lot of different flavors.
Yeah, absolutely. And we've actually been saying for years and years that we have to go upstream and do quality work on the front end to eliminate the back end denials. But even when that happens and is done well, you're still going to ultimately have some denials, right? So when you look at the kind of this like proliferation now of advanced technology, artificial intelligence, like all these things that are coming out, we're starting to see a lot of these niche vendors popping up that are starting to solve problems. Like, so for example, I spoke with an emerging vendor about 2 weeks ago, and their whole business model was downgraded DRGs to identify that and identify what the issue was, and then they automatically generate an appeal letter so that an individual can then fire that off. So I think about that, I think, hell, that is awesome. That is cool technology, but at the same time, what about all the other denials that are happening? So, that is one narrow thing, right? But I think the optimism then is, okay, well, we all know RevCycle is really about the one thing that's broken in the process, and then you fix the next thing that's broken in the process. So there is some optimism around, that process. But man, it's funny. 20 years ago, we were all complaining about denials as the #1 issue, and in our most recent research, guess what's #1? Still completely. So
it tends to be that kind of death by 1,000 paper cuts, and it's changing all the time. Will the payers ever expose, their front-end claim edits, or will they expose the prior authorization or, those sort of business rules? I know there's a fundamental mistrust between payers and providers, but if we just knew where the goalposts were, like, I think we would do a lot to, voluntarily like work within those parameters. But, do you think that ever happens at a larger scale?
I think it's a broad brush to paint all the health plans under the same one, although there's some consistency there. I think when we're talking about prior auth edits or rules, prior auth rules, there's already CMS requirements right now to publish those. And so a lot of health plans we talked to said, hey, we're already going down the path because we see this as a meaningful way to reduce friction, reduce administrative burden for us and for the provider. And then you have other ones that say, we'll do anything but not voluntarily. So once there's a requirement, and that's why you get some of the kind of the early stages of those prior auth rules. It's kind of clunky. There's a lot of data there. There's not, they didn't make these with the ability to kind of push a button and then publish them.
Yeah.
It's, there's work there to kind of get it. I mean, I remember on the provider side when we had to start publishing charge masters, it was non-consumable. It was just kind of out there though. On the claim edit side, it's a little bit harder. It feels like there's less willingness or ability to do that. And I don't know if there's some proprietary kind of partnerships they have through third parties. But then also, some health plans will say, those protect us from fraud, waste, and abuse.
Do you think that there's things that the providers don't understand about the limitations that payers have? Like, what's on their toes that we maybe underappreciate?
I think sometimes there's a wall there. I remember having a friend, and he was on a forum, kind of in a panel discussion, and they were talking about different reasons why different areas and departments within the hospital are investing in AI.
Yeah.
And the radiologist had all these things about what they're able to do with images and diagnosis, and kind of a lot of automation was happening. And then technology officer had some things, and this RevCycle leader said, well, we need to invest in AI because we need to combat what the health plans have.
Yeah.
It's kind of almost like described as kind of this arms race. And what I think we don't understand with health plans is a lot of times they're limited based on their technology stack.
Yeah.
They're very siloed. A lot of their systems are archaic.
Yeah.
And then also there's there's the employers
Yeah.
that they work with, and the constraints there, and kind of answering to them as a stakeholder into what they do.
Yeah. And having to receive data routinely from those employers too, right? Like that's one of the things that I think we get impacted as from providers. Like we want up-to-date eligibility data, and sometimes there's breakdowns there, and it just happens.
Yeah, the experiences I have is health plans are very intentional right now on really, it's interesting, we're doing a report around payment integrity right now, working on that. And that's kind of the opposite of the coin of revenue integrity.
Sure.
So you're looking for underpayments, they're looking for overpayments. And it's been interesting how much pressure they're putting on themselves to move that to the left and just say, hey, how do we just get this accurate in the front end?
Yeah.
So we really limit clawbacks, we do those things. And secondly, one of the outcomes that payers want us to measure is provider abrasion.
Okay.
And so that's been interesting. Now saying that and then executing and getting there is different things. There's an ocean in between that, but I see this momentum in this talk, and at the end of the day, I think we've had friends that used to work here and now they work on a health plan side, and they sit down and they're good people and they're working towards the incentives that they have.
Yeah. So what opportunities do you think exist between payers and providers to kind of streamline claims processing? And I'm talking mostly in like the acute institutional space.
Mm-hmm.
In the pharmacy space, you sort of get the real-time claim adjudication. Like you leave that day with your medication, you know what you owe, you've paid your copay, there's no bill after the fact.
Yeah.
Dental is like, I think similar, or most of the time it is, and maybe there's a copay here or there. Why don't we have a more real-time process? Or do you think payers will ever sort of get there?
It's tricky. I think the desire really is. I think a lot of times, going back to kind of what we were saying about archaic system and siloed, we say, hey, they just want to hold on to it at the very last second so they can collect all the interest, because at scale, that's billions and if not trillions of dollars.
Yeah.
I think the reality is, I think they're doing the best they can with the resources they have. Again, there's bad actors on that side too. But we're actually, one of the points of light are those case studies I talked about. We're doing one right now, we're just validating it, where it's a large health system in the Midwest, a national health plan, and they're using the core system of the provider as kind of this intermediary to pass the data back and forth. And they're trying to reduce the time on the DRG audits for inpatient stays. And where the baseline was it was 60 days after that they were closing those. 60 days after the patient's gone home and stuff, 2 months later, and they're trying to close those. And so what they've been able to do is reduce there were some allowances there because the provider's nervous, saying, okay, we don't want to just wide open the doors here, so you can go grab what you want. So there were some things saying, hey, we're going to grab the data for this purpose only, and for this use at the right place at the right time for the right reason. And what they've been able to do is reduce that by 50%. So it's about 31 days now that they're seeing. And what that means for the providers, they said, our turnaround time for claims has gone down 17%. And then also that, just specific to the health plan, it's reduced man hours by 247 hours in that time period. So, again, that's one health plan out of however many they work with, a certain percentage of their patients, but progress.
Before we continue, we wanted to thank you for tuning in. If you have questions or thoughts or just want to say hi, we'd love to hear from you. Send us an email at revcyclepodcast@adventhealth.com. That is REVCYCLE podcast@adventhealth.com. If you enjoyed this episode so far, be sure to like, subscribe, or follow so you never miss a new episode release. Now, let's get back to the rest of the episode. Dustin, we're going to transition to your area of expertise a bit here.
Yep.
So I want to talk about the current environment of revenue cycle and the utilization of technology. There's a ton of investment in the areas of generative AI and the use of other language and speech models and stuff like that. How much of an arms race is there out there among vendors making investments in these spaces?
Yeah, really good question. We're at a point in time again, like when you look at major disruptive technologies, you could go clear back to mobile phones, but then the internet. I really think this AI, artificial intelligence kind of arms race is significant. And in fact, we keep thinking, wow, there's all these great tools, but now they're even coming faster than we predicted that they were going to come. And so with that comes a significant amount of optimism that, oh my gosh, maybe we're going to get out of this dark night. Like we're going to have all of these things. So when you look at people, processes, and technology, right, historically, that's how we've viewed things. Technology is getting essentially all of the love.
Yeah.
But if you really boiled it down to, you're right, I think ambient speech is the thing we hear probably the most about. And what's interesting about that technology, by the way, is sure, it helps with clinician burnout, but there's so many downstream effects to that, right? So if you're essentially accurately coding, documenting first,
coding,
then you can better code that because you're owning all of that information. And then ultimately, can that even lead into a touchless adjudication where, and the idea is, yes, and initially it was more of a vision. Now we're actually wondering, hey, how many years away are we from something like that? So I would say for sure that, and then other specific, when you talk about AI, that covers a lot of technology, actually. That's a very broad thing to say, but we're starting to see, as I mentioned earlier, about a bunch of niche vendors that are starting to come in and solve specific problems. And so if that happens to be your headache and they have a gigantic Tylenol pill in the form of AI, that's awesome.
Would you say that like these couple of years are though about them kind of like these various companies and startups like trying to find their product market fit?
Yeah.
Right? That's kind of...
Yeah, that is a really good question. So one, these are new technologies, or I should say new use cases, applied use cases.
Right.
And when you do that, healthcare is difficult. It's not easy. So you have essentially the programmers that are trying to solve healthcare problems. There's going to be some, not train wrecks, but there's going to be certainly some bumps and bruises along the way. And so optimizing that is going to be a big thing. And then obviously scaling that, because what ends up happening...
It works everywhere, not just one place.
That's right. And if you come in and solve a specific problem, inevitably the provider is going to say to that vendor, hey, you did a great job. Why don't you now solve this problem? Let's do omni-channel communication, for example, or pulling down the patient invoices through your bots or whatever. So I think vendors also have this opportunity to
find other use cases.
To find other use cases.
Yeah, and I think it's, there's benefits right now if you're a startup, you're trying to grow a specific solution, but there's also a lot of hangups because, our patience in giving it time, we don't want to jump in anything unless there's clear outcomes. And yet it's beneficial because I think we're more desperate now as we're trying to do more with less, and I think there's some desperation and there's problems to fix. And if someone can get us there, I think if you're a health plan, it's interesting because they're looking at how long am I going to have this patient. So as they invest into technologies and things, they know that they turn over their patients every 12 to 24 months. And then they're going to another health plan. So as they even look at like formularies and some of those things, the decisions are very short windows.
We talked in the past about denials and prior authorizations. Like those are like really challenging things and kind of always have been for providers ever since the advent of managed care. What innovative solutions are maybe out there today that are, going to potentially help providers in those two areas?
Yeah. And this is, I don't want to, restate some of the denials piece, but we are seeing, I think if anything, we're seeing a proliferation of vendors. And because it is a broad topic, we are also seeing a lot of the incumbent vendors. So your core, your host system, we're seeing a lot of reliance on those organizations to provide that. And then some of your larger revenue cycle vendors, they're getting a lot of pressure on that. So I would actually say, and we have data, we're doing a report on it right now to suggest that the providers are looking towards the host systems or their core larger rev cycle vendors for these solutions. And that goes back to, historically, they don't want multiple vendor relationships. They actually would like to par that down. And so I think that is one of the challenges for these niche vendors is that you have to really prove your ROI before they're like, let's engage with another vendor, right? The plus one is always a difficult mindset. But anyway, so those vendors are actually, if you just pay attention to what's happening in the marketplace, when you see their banners and their websites, there's a lot around, hey, automating denials, et cetera. The prior authorization one is just such an interesting conversation because A, it's one of the largest headaches that we have. B, it really, when I say it's not really a technology problem, the technology vendors can ultimately do they can do the determination, they can do the submission, and then they can do the statusing of that. The question is, first of all, can they do it in all of the different ologies, right?
Yes.
For the different radiology and all the different settings, but are they also getting the information from the payers that they need in order to do that? And so you get a little bit, and it goes back to the conversation we had around payers, though. There's a little bit of finger pointing on that prior authorization. I've actually talked to many prior authorization vendors that are like, we are doing everything that we can. We need the payers to do X, Y, and Z.
So we've had a chance to talk about a lot of stuff today. What's a key thing that you would want to leave the listener with from our conversation?
You know, it's interesting. I had a conversation recently with a provider, and they were going from the provider side to the health plan side and leading interoperability at a large national plan. And we were talking about K2 and what we're trying to do to really try to build collaboration. And in some ways I said, you know, sometimes I feel like Sisyphus, just eternally pushing this rock up the mountain. And she said, you know what, at the end of the day, it just takes about 300 people, about 300 passionate people that do the right thing within their sphere. Yeah. You know, in healthcare sometimes, both on the provider and the health plan side, we can get a little bit myopic in our role. Yeah. And if we take a step back and see the broader view of what this means to our organization, our family, our broader U.S. healthcare, we tend to make better decisions. And when we do that, if we change and we win, you know, that's the goal, right? That providers and health plans can act collaboratively, and then they win in the market, and then everyone wants to copy. I mean, that's how healthcare really changes.
Yeah, I think that there's something about, you know, it is a small world sometimes in healthcare, even so. So yeah, it probably is right. There's 300 people or so that could really like move the needle on a utilization review or data sharing, you know, between payers and plans. I think that's probably right.
Well, again, on a smaller scale, you look at a lot of payviders, you know, provider-owned health plans. You know, they're essentially one organization, and we see, you know, initially, you know, with points of light, we're like, hey, if it's a provider-owned plan, should they submit? Should it count? And I was like, I don't know. And then I started interviewing some, and I found quickly it's either their best relationship or their worst, and it's very bifurcated that way.
It's very little.
And what does that come down to? That comes down to leadership, communication, transparency, and just kind of just like, hey, taking a step back and say, yeah, we're not going to waste this way.
So we've been internally on a little bit of a journey from like something I kind of term as a world-class revenue cycle to moving even further audaciously to preeminent. What does that mean to you? Kind of what can I sort of do to get to further down the chain to preeminent?
It's really fascinating to watch and talk to providers as we do our research. And the thing that always comes back to me all the time is technology is going to continue to evolve. Just like it has for decades, it's going to keep getting better and better. Payers, they're going to continue, and the government, they're going to continue to change rules and regulations and all that. So there's just this constant swirl of change, right? So we actually know that those two are incredibly consistent. Technology will get better, but these other things are going to change. And for me, what it ultimately boils down to is leadership, like people, and like, because people have to do all of this work. And I do get a sense at times, and I probably do this at work too, where I tend to look at like, oh, we don't have this technology, so we're kind of stuck. So we're just going to keep doing things the same way because this is what we have to deal with, right? But kind of finding that quiet moment of like really thinking through and go, wait a minute, why do we have to, even though we have this technology gap or whatever, we can do things differently. So I would like to see providers kind of owning that, going back to that a little bit and saying, hey, wait a minute, this is leadership first and then these tools second.
We talk to a lot of organizations, and there's some that, you know, we're talking about their technologies and they're using, and there's some organizations that say, well, actually, the vendor can do this and we're preventing them and, you know, our limitations. But I think, you know, the ones that do it well are hand in hand with their IT, they're hand in hand clinically, you know, and really everyone has a view of the how and the why. You know, sometimes physicians get frustrated with rev cycle and documentation and a lot of these other things because they don't understand the why. Yeah. And I think the organizations where they're working hand in hand and together are really, really ahead of the others.
Yeah, I think that's a perfect lesson. Before we let you go, we wanted to do like a fun segment. So we ask you to give a question to the next guests. And then the previous guest gave you a question. So that question is, what's your favorite video game or board game when you were growing up?
So I, you know, kind of came into my pre-teens in the late 80s. And so there was that Christmas morning, we got a Nintendo Entertainment System.
Yes. Yes.
And the Legend of Zelda owned
That
me
was-
for months.
Yeah, that was the game.
You know, and this is back in the day, you didn't have the internet, so we couldn't like go on and get cheat codes or anything like that. At school, we were passing papers, you're like with maps that we'd drawn out, and
They finally had some magazines eventually.
yeah, the Nintendo Power magazine,
yeah,
you know, got those in the mail and then kind of just opened my eyes and beat that game.
Yeah. What about you? A board game or video game?
No, so I grew up in that initial Nintendo era as well, and it was Tecmo Bowl. And so
Yes.
if anybody listening knows that if you got the Raiders and you had Bo Jackson,
He was
you never lost.
intense.
You never lost. You could just
Walter
run all over.
Payton was good too. Like I would, you know,
was
there were a
great.
couple of guys that were just overpowered.
But
Like,
my
they were
brothers
just-
and I would fight, like whoever was the Raiders, like I can't even play you. I'm not, you know. But anyway, and I'm not much of a gamer, although I have been known to download like a golf type.
Okay.
So I'm on the airplane and because I'm a horrible golfer, and so I get to live through these avatars that are hitting the ball really long and straight. Like I wish I could do that.
Boyd and Dustin, it's been great to have you guys and have this conversation. Really appreciate it, and thanks for being on the podcast today.
No, thanks for the invitation. We were excited to be here.
Thank you.
Thanks so much for tuning in to today's episode. Make sure to like and subscribe to our channel. We will see you next time.